It's a pleasure to talk with you this morning about something that's become increasingly of interest and I've been enthusiastic about, and that's the use of high-powered lasers for kidney stones. So for full disclosure, I am a consultant for Northern Litho. However, in terms of conflicts, they do not make any lasers, nor do they supply any of the lasers that we use, or that primarily I'll be talking about. Objectives, I want to talk about lasers. What are they? How do we use them? Review some of the data for the treatment of lasers and stone disease, and learn about its applicability for large kidney stones. So sort of a requisite slide when talking about kidney stones is talking about its prevalence, that up to 10% of Americans get a clinical stone. And I put clinical in italics there because a far higher percentage than that have kidney stones that don't present to the emergency room or pain or see a urologist. And of course, it causes all the things that we in this room know about. So for big stones in the kidney, PCNL has been a time-tested and recommended surgery, and to honor, recognize a leader, friend, mentor of this department, Bernie Litton, who died last year. He was the first to have performed a PCNL in the New Haven area in the 1980s. It's a major part of AUA guidelines, which I'm going to review in the next slide. I've performed somewhere around 600 to 700 PCNLs. So I am a believer. I do believe in PCNL. I enjoy the operation. Let's look at one of those AUA guidelines. So keep in mind the year of this last AUA guideline is 2016. 2016, that's going to have some relevance, as I'll talk about. But what do they say? So in asymptomatic patients with a total non-lower stone burden of less than 2 centimeters, clinicians may offer shockwave lithotripsy or ureteroscopy. This is a strong recommendation and a grade B. I can talk about how these things are classified if someone wants to hear them, but I will talk about the grade in just a minute. In symptomatic patients with a total stone burden of greater than 2 centimeters, clinicians should offer PCNL as a first-line therapy. So first line is the emphasis there. And this is a grade C. I'll tell you what the grade C is in a minute. Clinicians should inform patients with lower pulse stones greater than 1 centimeter in size that PCNL is a higher stone-free rate, but greater morbidity. Strong recommendation, grade B. And in patients not considered candidates for PCNL, clinicians may offer staged ureteroscopy. And it says may offered, again, grade C. So grade C says, and this is directly from the AUA guidelines, and this grading system applies to all guidelines. It's not just to stones. So whatever the guideline is that you're reading for whatever area of urology, these grades apply. And grade C says, grade C evidence is evidence about which the panel has a low level of confidence. And when body of evidence strength grade C is used, there is uncertainty regarding the balance between risks, benefits. Alternative strategies may be equally reasonable, and better evidence is likely to change confidence. And I did not add the italics. That's in the original document by the AUA, stressing likely to change confidence. So maybe today I can present some data to you that says that maybe these things should change, that maybe PCNL should be one of several first-line therapies rather than the first-line therapy. Maybe patients who are not considered candidates for PCNL for a variety of reasons, and we'll go into some of those reasons, instead of maybe offered stage URS, maybe it should say should. All these words on AUA guidelines are big deals when you change a word from maybe to should. And I'm suggesting that that might be a change that can come up. So why do something other than to set time-tested operation? It's used for big stones. It works very well. Well, it's an expensive operation. There's a lot of disposables and other equipment. And I see Peru's taking pictures of my slides. This is a little unfair because we're going to have a debate on this. And it's happening next weekend, and Bruce is seeing all my ammunition here. But it involves at least an overnight stay, which is a cost to the system and inconvenient to the patient. It's a high skill set to be able to use this operation on complex stones and get the patient stone free. Increasingly, more of our patients in all fields of urology, including stone disease, are on anticoagulants, which presents a problem. There's an incision, there's scar, there's post-op pain, there's a recovery time, which is an inconvenience to the patient and a cost to society as they're missing work and other productive things that they could be doing. And there are complications from PCNL. So in Journal Club, we started reviewing landmark papers. This is one of the landmark papers in this field. There's a group that's the acronym is CROWS. It stands for Clinical Research Office of Endourology Society. This is a group of many urologists all throughout the world who have developed this research consortium pooling their data. And in 2011, they pooled their 5,800 patients and reported on the complication rate from PCNL. And the bottom line about the complications is that there's about a 20% complication rate. You can see what those complications are. About 10.5% are fever, 8% significant bleeding, 6% blood transfusion rate, 3.4% renal perforation, and almost 2% of hydrothorax. So whenever talking about stone disease research, clinical stone disease research, like when there's a cancer paper, you can't have a cancer paper talking about treatment of cancer without talking about the cause or cancer-specific survival. Similarly, when talking about stone disease, you can't have a paper without talking about the stone-free rate, or SFR. So they report on their stone-free rate. At 30 days, it was 76%. So 76%, I think, we look at our PCNLs, and we always do CAT scans on our PCNLs, and I think we would be a little disappointed if a quarter of the time our patients had stones on that post-op day 1 CT scan. But keep in mind that only 14% of these patients, 14% had a CT scan. So even though the stone-free rate is being reported as 76%, it's probably significantly lower than that. And again, this was an older study. You can see it was in 2011. And so hopefully most of these people are now doing low-dose CT scans. This was prior to our BMJ article coming out that showed that low-dose CT scan has a large applicability for stone disease. At the time that we published the paper, only 2% of academic institutions, not private practice, but academic institutions were doing low-dose CT scans. So hopefully that has changed. The reoperation for stone rate was just over 15%. And also keep in mind that some of the surgeons who are in this group are people that are kind of the who's who of stone disease, like Dean Asmos, Mahesh Desai, James Lingaman, Michael Grasso, Steve Nakata, Robert Nadler, Peggy Pearl, Glenn Preminger, Art Smith, Stuart Wolf, some of which have given us, have been visiting professors here, and many of whom belong to GU surgeons. So if only there was some technology that we could use that might be able to break up stones and reduce morbidity. What's interesting is the person who invented the laser, his name was Theodore Maiman. He invented it in 1960. He was in World War II and then went to Stanford, got his PhD. 5 years later, joined Howard Hughes and invented the laser, published it in Nature. And he died not long ago in 2007. And his primary rival was a guy named Charles Townsend, who said at his death in his obituary, he said, word for word, his paper in Nature is probably the most important in the last 100 years. And who knows what's the most important? There's so many Nature papers that have led to Nobel Prizes and have changed medicine, certainly. But when you think about laser applicability, obviously in medicine, in the military, and semiconductors and technology, it's brought cat lovers and cats pleasure throughout the world over, so maybe it is one of the most important discoveries. But laser, if we think back to physics, it's an acronym. It stands for light amplification by stimulated emissions of radiation. How does a laser work? This is a basic. Lasers can be developed in gas. We know of that, like CO2 lasers that are used in urology, and there can be solid state lasers. This is a solid state laser that we use. It's solid state because there's a crystal here. It's made of yttrium, aluminum, and garnet. And fused in it are these holmium ions. And there's white light that shines through it, just regular white light. It's in a pulse fashion. It excites the electrons in the +3 holmium cations to a higher energy state when you think back to chemistry, and it goes into a higher orbit. And then as it comes back down to its orbit, it releases a photon, releases energy, a photon, and that photon bounces around and releases more and more photons that then escape and give you the laser. So pictorially, you can see here that you get some photons that get released. It bounces off of these mirrors, and it bounces back and forth, and hence the light amplification emitted emissions of radiation that escape through a tiny pinhole, and that becomes your laser feeding into the fiber. So I want to show you one of the high-powered lasers that we've been using. And compared to a regular laser, you can see that this is the bubble that comes out. Let me just pause for a minute here. So when a laser comes out, part of the energy vaporizes the water between the laser fiber and the stone. So you get some water vaporization as it comes out, and then some of the energy is going to get to the stone. So here's a regular laser. You can see it vaporizing the water. And I want you to focus on the water vaporization and how far that laser goes. Here's the Moses one. So it sends out an energy that vaporizes the water, and then through that vaporized water, it shoots the energy out to the stone, hence the name Moses, right? Parting the water. And so you can see that the amount of energy can get more because it's not being blocked and absorbed by the water, and it can also get further, so you can hit more of the stone. So you can see ultimately where the end amount of that energy is further, as demonstrated here. I was asked for the people on Zoom to show this video again. It didn't show the Moses. Here it is. So again, you can see that initial cavitation bubble vaporizing the water, and then through it, another pulse energy gets shot to the stone without being absorbed by the water, hence the greater efficiency of the laser and the farther reach of the laser power. This is called pulse modulation. So although we use the Moses here, I will, just for thoroughness, mention a competing laser. It's called the thulium fiber laser. You can see here that it's not a solid state laser fiber. It's not a solid state laser. It's actually a laser that's developed within a fiber. So there's this fiber, and it's laced with thulium, which is also a +3 cation. There's basically LEDs that shoot energy instead of white light. And the LEDs are set at a frequency that is just right to get the electrons of the thulium laser to a higher orbit. So it doesn't use as much energy because there's not a lot of wasted energy. It's just that particular wavelength to get the thulium excited and get the photon developed. And then it bounces around through this laser and exits through. There's very clean coupling between the laser generation and the output through the fiber. And that leads to some possible advantages. So it plugs into a regular power outlet. The Moses doesn't. I can go into further details about that, but you need a special electrical outlet for that. It's quiet with a small footprint because it doesn't generate a lot of heat. So you don't need this water cooling system and a big fan. So it's a small box. Because there's good coupling between the laser generation and the fiber, you can have smaller fibers, even up to 550 microns. And with a smaller fiber, you know that you're using less of your working channel, so you get better irrigation, better visualization. Its frequency is tremendous. This is one of the alleged advantages of it, is that it can go up to 2,000 hertz, whereas the home YAG is about 80. It's a long pulse rate. I can talk about that, but basically it's on for a longer period of time, so it's hitting the stone for a longer period per pulse. Its wavelength, there's some relevance to this because the wavelength is a little bit less than that for water vaporization, so less of it is absorbed by the water. But there's, like many things, there's also downsides, or possible downsides, that it can generate more heat in the collecting system, less fragmentation abilities, and therefore potentially a less versatile laser. So as I'm going to show you some data, I want to make a disclaimer that I'm not showing you some of the, there are many studies that have used this Moses laser. Most of them are studies that in essence are, look what I could do, look what I did, here are my patients that I did, without really a comparison. And I'm not showing you those studies. There's even a few meta-analyses that are available where they compared high-powered lasers versus low-powered lasers. But again, in those meta-analyses, it's sort of compiling a bunch of people that showed what they did with the high powers and a separate set of people and patients that they used for low power and comparing them, which I think is not helpful at all. I'm not showing many PCNL data. Dr. Mona Medinia will be talking about that at the Bulldog debate. I just have one slide. I'll be talking a little bit about it. And a warning for those who faint at heart, these are thus far really bad, scary bad studies that I'm going to be showing you. So there's really a paucity of good data, which potentially presents a rich opportunity. And I'm going to show you some of our preliminary Yale data. So, of course, practice-changing things often come from randomized clinical controlled trials, RCTs. And here's a randomized clinical trial that was published in 2020. And they basically randomized patients to either get the Moses energy or to get standard energy. And they had 36 patients in each arm. They were well balanced in their randomization in the size of stones, the density of stones measured by Hounsfield units, the number of stones, location of stones, composition, and whether they used your ureteral access sheath or not. The average size stone was about 1.5 centimeters. However, there were some slight differences that were close to statistically significant. More in the regular laser mode were pre-stented with a P of 0.06, and more had ureteral access sheath in the regular laser than those in the high-powered laser, P of 0.08. So a trend, perhaps, and may have some relevance on their findings. So the results. So you can see that their procedure time was about 10 minutes less, which is 20% faster with statistical significance. Their fragmentation time, 7 minutes less, 33% faster with a significant p-value. Retropulsion, so when treating a stone, you're delivering energy to that stone. That stone will have a tendency to move away from you because you're hitting it with energy. And sometimes it can be problematic. You can take a nice, easy case with a stone in the ureter and it can fly into the kidney and become a much bigger deal. And like we talked about, if you're not directly touching the stone, that energy is ineffective. So if that stone is moving away from you part of the time that you're engaging with the laser, then you're not effectively treating that stone. So they subjectively rated their retropulsion on a scale of 1 to 3. And with the standard laser, they said that their retropulsion was on 1 out of 3. And with the Moses laser, they said it was 0.5 out of 3. Again, in their analysis, that was statistically significant. Their complication rate was similar, and their stone-free rate was similar, about 88% for stones that were 1.5 centimeters on average. Significantly though, and this is something of debate about how do we define SFR, stone-free rate. They did it by CT, which is great. All of them had a CT at 3 months, which is very good. They said that stone-free was less than or equal to 4 millimeters. And they're not alone. There are many studies that define stone-free rate with that kind of a definition. I think that when all of us think about being on call, we've certainly seen plenty of patients that come into the emergency room with a 4 millimeter stone in their ureter with pain, and some of which you are taken to the operating room. So I'm not sure that that's a good definition of SFR, but that's what they used. And again, they're not alone in that. Some caveats. The authors were consultants for Luminis, which makes the Moses laser. It's subsequently been bought by Boston Scientific. The study was paid for by the laser maker. They included 25% of their patients had ureteral stones. And I don't think it really makes sense to do it for ureteral stones, especially when we're thinking about the applicability of this for large renal stones. Stones tend to not move as much in the ureter, they're easier to break up. I don't think the Moses adds as much of an advantage there. And I was wondering if it's really blinded. I haven't done this yet since looking at this study, but I feel like I would be able to know if we were on a high-powered laser setting and dusting versus not. And the next time we're over at SRC using it, I'll put that to the test. But I feel like I would know. I may be wrong.
Sorry, did you mention that they use the same like technique as far as dusting and settings?
They did. Yeah. They were just blinded to the setting. Yeah. So again, a disclosure about this study, about this concept. There are some studies that exist where they did not show an advantage to the Moses laser, but they were not randomized, and the majority of publications out there, and again, it may be an issue of positive results reporting. The most of the studies show a difference with the Moses laser. So again, let's look at another RCT randomized clinical trial with using this high-powered laser for intrarenal stones versus PCNL for stones that are greater than 2 centimeters. So in this study, they had roughly about 60 patients in both arms. And again, admirably, everybody got a CT scan 6 weeks post-op. I looked very closely in the materials and methods and could not find what kind of laser they used, which is kind of strange for a publication, right? The whole point of materials and methods is so somebody else can reproduce what you've done. And when you look at all the materials and methods, for example, a Da Vinci case, it'll always say in the methods, Da Vinci, parentheses, intuitive, Sunnyvale, California. They didn't say anything about their laser, which is a little bit strange, but it was in March of 2018 that they started the study. The Moses laser came out in 2017. It wasn't widely used as soon as it came out. So I'm thinking that they did not use a high-powered laser. Again, an RCT. Let's look at their data. So they were balanced for age and gender. Probably most importantly, stone size was well balanced and pretty good sized stones. There are 2.8 centimeters of stones in both groups. It's a fairly large stone. The density of the stones were well balanced. This table was taken straight from the paper, and I'd like to direct your attention that some of these stones were on the right side and some of them were on the left side. Let's look at some of the results here. So the operative time for these cases were pretty good. I mean, you're using a Moses instead of a PCNL, and yet their operative time was similar. Their stone-free rate, again, as defined by CT scan, was similar. And about, interestingly, almost exactly the same percentage you saw from the Crow study on stone-free rate. The stones that were less than 4 millimeters, you can see, again, equal with a p-value of 0.22. Look at the blood loss, though. Their blood loss was the same. Blood transfusion rate was the same. Hospital stay was the same. That's a little suspicious, right? So when we think commendable in one sense. It's a randomized clinical trial in surgery. We don't see that a lot. It's a great thing. They got a CT scan on all patients 6 weeks later. That's a great thing. So we don't have to compare apples and oranges. Well, they got the same study. But whenever we look at these papers, we wonder, are they applicable to our patients? Well, why were patients getting a ureteroscopy in patients for 2 days, 38 hours? That's not our patients. Why was there no blood difference, no blood loss difference in PCNL versus ureteroscopy? That's just simply not believable, right? Where were the stones being treated? Were they in lower pole, upper pole, in the renal pelvis? That's important information. And how about the retreatment rate, emergency room visits, discomfort level? We don't know those things. And no mention of the type of laser, although, as I said, I don't think it's a high-powered laser. So let's look at another randomized trial. So this is a recent article. This is just a few months ago in July 2023. It was a comparative analysis of ureteroscopy versus mini PCNL for stones that were 2 centimeters or less in the kidney. So again, let's go straight to table 1. And you can see that they were well balanced for many of the usual criteria like age and BMI, comorbidities. Importantly, when looking at multiple stones, they were balanced, but with stone burden, it was a little bit higher for many PCNL, a little denser for many PCNL, and relatedly radiolucent stones. So there was some differences between the two groups and the types of stones they were treating. Importantly here, you can see that the stent duration, of course, is different for ureteroscopy because most of those patients are getting a stent. They said, again, there's no change in the hemoglobin or blood transfusion rate. The length of hospital stay was also equivalent to both of them with a 16-hour stay for ureteroscopy. Also importantly, you can see this 27%. That means 27% of these patients were reoperated on, which was statistically significant. The first day after surgery, they all got imaging, what was their imaging? It was KUB and/or ultrasound. So not the CT scan that other studies showed. And there was a difference in stone-free rate favoring many PCNL 1 day after surgery. But when you look at it at 90 days, because a lot of these are small fragments, they're dust, it needs to drain out. At 90 days, they became equivalent. However, let's look closer at this. Why were they including bilateral stones for ureteroscopy, but not for many PCNL other than one? I mean, it's not really comparing the same type of patients, the same type of surgery, the same time in the operating room. Why is the transfusion rate 25% for a mini PCNL? It's certainly way higher than we typically do. This might sound familiar to the residents because we looked at this in Journal Club as well. Why are ureteroscopy patients staying 2 days? That's definitely not our patients, our practice. And if they couldn't get a ureteral access sheath up, they aborted the case. They just put a stent in, didn't treat the stone. And of course, that's not our practice, right? We don't leave the patient there unless there's some real reason we can't get up the ureter. We'd still go up the ureter and dust the stone. So that may account for their 27% reoperation rate. That would not be our patients. And it's here again, they didn't talk about what the laser they were using, but they did nicely talk about the settings of their lasers. And from this, you can see they were definitely not using a high-powered laser. So all of this argues for, well, there may be some noise there showing us that even with a non-high-powered laser, they're getting reasonable results, although not great studies as we talked about. But with a high-powered laser, maybe we can get a lot better results than this. So let me talk about the Yale experience. So this was presented by Amir Khan at the New England AUA section, and since that time we've updated the data. This is definitely a very preliminary analysis. This is a work in progress. There's a lot of data that's missing, and we really need to strengthen it up. It's a retrospective study based on prospectively kept database. It's a cohort comparison. The surgeons involved include myself and two highly skilled surgeons, Dr. Tim Tran and Dr. Prusmo Medinia. There are shortcomings, and I'll highlight some of the shortcomings as data compilation is still underway. So methods, as I said, it's a prospectively kept database that we enter at the time of surgery, the very moment of surgery. It's from August 2020 to August of 2023. And we're looking at using specifically laser for ureteroscopy versus that of mini PCNL and PCNL for stones that are between 1 and 2 centimeters. Exclusion criteria, we didn't include any lower ureteral stones. If it was something at the UPJ, proximal ureter was included. We didn't look at staghorns, naturally between 1 and 2 centimeter stones, and we excluded bilateral cases. So we're trying to compare the actual operation without changing the types of patients that are treated. For patients with multiple stones treated with one procedure, the aggregate size stone had to be between 1 to 2 centimeters. So there's some patients who might have an 8 millimeter stone, let's say 3 8-millimeter stones. That would be included as total aggregate stone between 1 to 2 centimeters. So the number of patients for the Moses was 31, for PCNL was 29, and for mini PCNL is 2. And you can see that the amount of stone that's being treated, the aggregate stone diameter, is similar between all 3 groups, no statistical differences, somewhere around 1.5 to 1.7 centimeters of stone being treated. The length of the procedure in minutes, and how is the length of the procedure defined? So it doesn't take into account positioning and all of those other things that take a little bit more time with PCNL. This is from the time the procedure starts to the time the procedure stops. And you can see that the length of the procedure was statistically significant for all of the groups in differences. So Moses was less than PCNL and less than mini PCNL with strong p-values. And the minutes of difference were fairly significant. These are real changes in duration of procedure. Total radiation dose, again, it makes sense when you think about how they're being done. And as the residents know, this is something I talk about and think about, our radiation exposure. And there's a drastic difference in the amount of radiation that not only the patient is getting, but all of us are getting as we're operating on these patients. And you can see that's markedly statistically significant, and not just statistically, but I would say that over 20, 30, 40 years of a career, that's a meaningful difference of radiation exposure. Fluoroscopy time, as you would imagine, your foot is on the pedal less for a ureteroscopy using the Moses laser than for PCNL and mini PCNL. The Hounsfield units, so it would be important to know that you're treating similar kinds of stones. So you want to know that they're similar kind of densities as measured by Hounsfield units. So you don't want to skew one group to have soft stones that break up quickly and make your data look better. But you can see here the Hounsfield units for all 3 groups were equivalent. The laser energy used, the main thing to look at here is the amount of energy used to break up these stones. So to put this into context, for a typical stone that you guys were treating on a on-call weekend or something in the ureter, 5, 6, 7 millimeter stone in the ureter, you're probably using somewhere between 1 to 4 kilojoules of energy. And you can see here, this is a significant amount of energy, 21.8 kilojoules of energy. Some patients who are in the PCNL and mini PCNL also were having lasers used. Intraoperative complications. So again, when talking about surgical procedures, it's great to talk about how long things take and other things like radiation, but what about, are you subjecting patients to higher rates of complications? So It's a small set. We had 3 intraoperative complications from the ureteroscopy group and none from the PCNL, mini PCNL. And again, these are only intraoperative complications, not post-op complications. So it's not taking into account if someone got blood transfusions the next day or had an ileus or some other injury that was detected later. So what were these 3 intraoperative complications? I thought I would show them to you because not only is it illustrative of the complications that occurred, but also the types of patients that I'm using this on. And for full disclosure, not to throw my colleagues under the bus, all 3 complications were my complications. The first one was a 36-year-old male who had a 1.6 centimeter stone at the UPJ. He had polysubstance abuse and a fairly significant one, so I was trying hard to not do a procedure that would induce much pain and keep him away from narcotics. And we had a tear in the proximal ureter. It didn't look like full thickness, but there was some extravasation. This is fluoroscopy at the time of this actual patient with just kind of doing it in cine mode. You can see the ureteral access sheath going up. The scope then goes up. We treat the stone. You can see some extravasation. And the stent is up. So that was one such complication. What happened to that patient? Well, this patient had their stent removed 6 weeks later, had their stent removed, and then 6 weeks later had an ultrasound. There's no hydronephrosis, bilateral jets were present, no stones were seen. And not only that, but 2 years later, the patient came back to our hospital, to the emergency room for a rule out appendicitis and had a CT scan of the abdomen and pelvis, and there was no stones, no hydronephrosis. Case 2, this was a 56-year-old woman who had a very significant number of medical problems, as you can see. Coronary artery disease, congestive heart failure, CKD, COPD, diabetes, hypertension, an MI, stroke. And she just had this tremendous smell of smoke when walking into the room to examine her. She had some significant stones that were causing her problems with pain. One was at the renal pelvis near the UPJ that was 17 millimeters, and another one that was 7 millimeters in a lower pole calyx, so 2.4 centimeters of total stone burden. She had a very narrow ureter, we coaxial dilated. She had a very tight urethral orifice. And at from 7 to 9 o'clock, from 5 to 6 o'clock, there was a mid and distal ureteral perforation. A year after the stent was removed, she had an ultrasound, no stones, no hydronephrosis, and bilateral ureteral jets were seen. Third case, 43-year-old woman. She had a 16 millimeter lower pole stone. It was 9 millimeters. She had a CT scan here at Yale. And carefully looking at that CAT scan demonstrated that there was 0 stone. So it's an impressive progression of stone over a relatively short period of time for her. She had 3 mucosal tears, but muscle was seen intact. Her stent came out, and then she had 2 ultrasounds. Same story. No stones, bilateral ureteral jets were seen, no hydronephrosis. So bottom line is there was no sequelae and all stones were removed in all 3 patients. Now, perceived stone-free rate. So when we fill out the day of surgery data that goes into this database, one of the questions is, do we think we've rendered them stone-free? Do we see fragments left? Do we know that we're going to need to come back? And based on our perception of stone-free rate, you can see that there's no statistical difference between those that had a Moses ureteroscopy, a PCNL, and mini PCNL. But there are significant limitations, no doubt. And there's no standardization of post-op imaging in these patients. And we haven't even compiled the delayed imaging. I showed you those 3 complications, but we have to collect them for all the patients. We need to account for how many of them represented to the hospital or had further surgery for the same sided stone. Need to account not just for the intra-op complications, but also post-op complications. Need to account for those who needed repeat surgery on the same kidney, and in what time frame. Is it something we came back for a stage procedure a few weeks later? Did they come back a year later because we left something as an itis and had additional stone that needed treatment? We need to account for post-op discomfort. So there'll be some more pain with an incision in the back, and they'll be on some narcotics, but also those who have ureteroscopy will have a stent in, and many of those patients will have discomfort. They'll call the office. They might have emergency room visits for stent colic. We need to account for all of that. I need to look at cost analysis, both for the operative costs and the overall costs, because some of the patients are going to have hospital stays that can be quite costly. So where should high-powered lasers be used? So with all this background stated, let's get to the bottom line of where I think we should be using this laser. So I'll start with the no-brainers, which are the patients who have stones that are between 1 to 3 centimeters in size in the kidney, but it's not just that, but also might be on anticoagulation for major critical reasons like CVA, TIA, drug-eluting stents, coronary disease, DVT, factor V Leiden deficiency, and other thrombotic risk situations. This isn't just a list of like, yeah, that sort of applies to some patients. As all of us in this room know, there are lots and lots of patients, and it's increasing year by year, the number of patients who are on these kinds of medications for these kinds of reasons. So it is a significant subset of patients that have this. Patients who may be limited in their prone ability, morbid obese patients, poor ventilation, excessive skin to stone distance. And again, I know Dr. Mondini will talk about some supine patients that can be done. Those who refuse PCNL or PCNL, which actually happens. Complex intrarenal anatomy that might require multiple punctures to get to all the stones and render them stone-free. Oftentimes when you go in a retrograde fashion, you can get in little nooks and crannies of the kidney that you can't do when you're doing it via antegrade approach. When you're doing a ureteroscopic approach and you don't want to use your ureteral access sheath, there's not a ton of those patients, but there's some that have small ureters. Young patients sometimes are that way. Ureteral strictures. And then, so to me, I think these are the no-brainers. I think that, frankly, I think that AUA guidelines should change because for me, these are the no-brainers. I think this really plays a role. And I think those statements that we went back to where it says PCNL should be the first-line therapy, I think that it should be modified to say that ureteroscopy could be used in selected patients. These are those selected patients. Where it says PCNL, where patients can't have PCNL, maybe they should have ureteroscopy. I think it should be, ureteroscopy should be offered to them for these patients. Relative indications. So these are not the no-brainers. These you can argue, but those who wish to have less downtime post-surgery, but an understanding that for large stones, they may need a stage procedure. You may not get all of it with ureteroscopy. Those who want simultaneous bilateral kidney surgery. So yes, you can do bilateral PCNL. Yes, it is done. It's not a common thing. You are putting 2 kidneys at risk at the same time. But with ureteroscopy, it's very common to do bilateral stones. So it could be somebody who's got a large stone in the kidney that's a 2-centimeter stone, and they have a 6-millimeter stone on the other side. They've been in the emergency room with multiple stones over the years, and they say, "Doctor, while you're there, can you get my other stone at the same time?" And one position, one anesthesia, if that would be a reasonable thing to do. A solitary kidney, I think you're putting it at less risk with a retrograde approach. Similarly, a transplant kidney, I think you're putting it at less risk with a retrograde approach. We try to do them just, this is timely, just yesterday, we did a transplant kidney PCNL because we tried to do a Moses, but had a transplant ureteral stricture and we couldn't get up in a retrograde fashion. 2-stage PCNL, so you do a PCNL, you try and render them stone-free. There's some stones and little nooks of the kidney that you can't get to, and you can come back and get additional access and try and do it again. But you could also clean up with a Moses laser, which is something we're doing on another patient that we just finished maybe 2 weeks ago. Like the patient I presented, if you're trying to stay away from opioid use, that might be a patient that's a relative indication to do this type of procedure on. Now, I should say that I, of course, presented, my goal here was talking about high-powered lasers and ureteroscopy, and I'm coming up on my hour, but I didn't talk about PCNL use and mini PCNL use, and they certainly have a role, no question about it. And you might wonder, well, what is the role, and compare and contrast? Well, this is going to occur this coming weekend at the Bulldog debate. This is going to be moderated by Tom Chi from UCSF, and Peru's Motivadinia is going to take the mini PCNL stance. Dr. Tim Tran will take the PCNL stance, and I'm going to be arguing about ureteroscopy, which Peru's has now seen all of my armamentarium. And that's my talk. Thank you very much. I'd love to take any questions.